Okay, thank you. Welcome everybody to this EURO-NMD webinar on inflammatory myopathies that will be delivered by Professor Werner Stenzel. As you know, these webinars are organized in collaboration with the European Reference Network for Rare Neurological Disorders and with the European Academy of Neurology. We have now and today the opportunity to listen to someone who has a very known work done around inflammatory myopathies, Professor Werner Stenzel, that is a neuropathologist and a myopathologist that runs the unit in Berlin at the Charité Hospital and is also co-director of the German Reference Center for Neuromuscular Disorders. Is interested particularly in juvenile and adult forms of myositis and also inflammatory nerve pathologies. Many people go through his lab in training as obviously the prestigious team that he runs is obviously one of the peak authorities in those pathologies and others, and is got a focus on ultrastructure myopathology and uses it both in diagnostic routine and to answer research questions in trying to identify and characterize the morphological features of these entities. He has the position of associated editor of the Journal of Neuromuscular Disorders and is executive editor of Neuropathology and Applied Neuropathology. And without further ado, I thank Werner Stenzel for accepting to deliver this webinar and would like to pass on the floor to you. Thank you.
Thank you for these kind words, Antonio, and I must say I'm really honored to be here and to talk. Although this is, of course, delivered by the internet, but nevertheless, I'm really very happy to be here, and I realize that although we are approaching Easter, there are still 45 people who are up and standing and want to hear about inflammatory myopathy. So I'll try to do my very best to deliver an interesting speech. So, oops, wait a minute. Yeah, what is it all about? We have different types of myositis, and I think in the past we all know that myositis was basically called by three entities: dermatomyositis, polymyositis, and inclusion body myositis. But this has now changed since several years now, I would even say decades now. And we can differentiate in a first approximation the idiopathic inflammatory myopathies most people talk about, especially when those people come from neurology. But nevertheless, there are also a huge number of other entities also falling into this group of myositis, which are more frequently treated by rheumatologists. And those are the overlap syndromes like scleromyositis, Sjögren syndrome-associated myositis, and others. There's also a relatively rare entity called eosinophilic fasciitis. Something that is really important are the IR types of myositis. This is probably also not a single entity, but nevertheless important to talk about, and I will talk about this later. There's also sarcoidosis and other granulomatous types of myositis, and of course post-viral myositis, which has attracted some attention recently after or during COVID. We are still in the COVID situation, of course. And there may be others I will not talk about. Those are the pathogen-induced types of myositis, which are relatively frequently seen in other countries, like in India, in Africa, etc. So this may also occur, but not so frequently, at least in Germany. So those are the types of myositis. Just to say that the first row is the ones that most people allude to if they talk about and discuss about myositis. They are discussing about the idiopathic inflammatory myopathies, and I will talk about those four here first, and then later talk about the others as well. So there are two very important messages I'd like to deliver right up front, right in the beginning of the talk. One message is that the autoantibodies, and I will always come back to those during the talk, the autoantibodies are really important. And there are several ways to test them all over the world, which are very different, but in a way comparable. But there's still work to do to harmonize the way how to test these autoantibodies. But just to give you an example, we have several diseases in rheumatology, but also in neurology, where the antibody as a pathogenic mechanism or as a pathogenic element in the disease is very well established. Just think about myasthenia gravis and others, of course. In myositis, this has long been a little bit discussed. Are they only accompanying myositis, or are they really deeply associated with myositis, and in which way are they associated? And during the last couple of years, it has become clear that there are some types of autoantibodies, namely these 5 here on the right, associated with dermatomyositis, but still there's around about 30 to 50% which are seronegative and still must be called dermatomyositis. There are 2 antibodies that are paradigmatically associated with immune-mediated necrotizing myopathies, and they are called anti-SRP and anti-HMGCR. There is one which is associated with IBM. This antibody probably has a different connotation. We'll talk about this later. And there are several antibodies that are associated with overlap myositis subtypes. And I would say that those here in the middle, the antisynthetase syndrome associated antibodies, form an entity apart that should perhaps not be placed among the overlap myositis, but this is also a matter of discussion and of definition. Anyways, what is important to take home already at this stage is that these antibodies are really important. They define certain sub-entities of the disease. They help to delineate them, but sometimes they also cause trouble in a way that, for example, an antibody may be present and the patient does not have the disease. So then it is questionable what this antibody, the presence of this antibody tells us. Anyway, we will discuss this later and during the talk. So the important message here, they are important, and it's important to ask for them and to tell the lab, the laboratory to assess them. The other very important message is that there are certain types of interferon-mediated signatures on a functional level that are associated with certain diseases. And one of which has really emerged also already since like 15 or more years is the so-called type 1 interferon signature. Many of us know the interferonopathies, the genetic types of interferonopathies, and now it is well agreed upon that the subtypes of dermatomyositis can be called acquired interferonopathies, in a way that these dermatomyositis, all dermatomyositis subtypes, irrespective of the antibody, always have a strong type 1 interferon signature in the tissue and also in the blood. So this is something that is functionally close to what happens in so-called genetic interferonopathies that occur at a different age, mostly in children, and this here occurs in adults. Another disease more from the rheumatology context that has a strong type 1 interferon signature is lupus, for example. And there is some overlap with this as well. There's also lupus-associated myositis. And what you can see here on this graph, taken from a publication by Iago Pinal-Fernandez from Andy Mummon's lab, now he's a full professor, I think, is that some of the diseases here, like the dermatomyositis cases, they all have this interferon signature, which is exemplified here by only looking at, I think it's 10 different genes that are upregulated. So this was done on the mRNA level by RNA sequencing, and they found that those are here upregulated. And when you look at the necrotizing myopathies, which are here, you can see that there is no relevant type 1 interferon signature. When you look at the antisynthesase syndromes, they are a little bit more close to what happens in dermatomyositis. And at first sight, I must say that it is sometimes the antisynthesase cases look a little bit similar, like dermatomyositis cases. They have been intermingled in the past, but there are clear ways how to differentiate them. And they have these antisynthesase syndrome cases exemplified by the presence of, in this case, the GO1 antibody. There are others, of course, that you can see here, PL7, PL12. They have a different interferon signature, which is not the same as you can see here. And we all know, or we must think about the type 1 interferon signature as a so-called signature involving hundreds of different genes that are upregulated. And those are only the ones that have been agreed upon to serve as a markers or as a group of markers indicating type 1 interferon activation. And this comes again from lupus research. So in daily life, what can we do if we don't want to look at hundreds of genes? This is not possible all over the world, of course, and we do not want to do this in daily routine. So in daily routine, we can use this type 1 interferon signature by two relatively simple things. First, we can stain with an antibody which is directed against MXA. And this is firmly established now. This is one of the markers that is visible here, for example, MX123 or MXA. And this tells us that there is a type 1 interferon signature in the muscle tissue. You can also look at so-called tubular reticular inclusions on transmission electron microscopy in endothelial cells. And those are here, these tubular reticular inclusions. You can nicely see them in the endothelial cell here. And this also tells us that there is an interferon signature, and this has been known for some decades now already. So if you have those two items here, it's very likely that the disease is a type 1 mediated disease, type 1 interferon mediated disease, corresponding to dermatomyositis, but it can also occur in HIV-related myositis or in lupus-associated myositis. So I like to think about dermatomyositis as a spectrum disease because these different subtypes of disease are really very different. And I will show you in which way they are really different. So there are 5 different autoantibodies. The SAE antibody is exceedingly rare, but the others are relatively frequent and differ a little bit all over the world in presence and in frequency. But there are very clear clinical variability among these entities here, sub-entities, and there's clear morphological variation among them. And this is something that I am here to tell you and to show you that you can really differentiate them by looking at the different morphological features that I will show you. So the first type of dermatomyositis I'd like to talk about is the MDA5 positive dermatomyositis, which has in the past been called amyopathic dermatomyositis very frequently. Amyopathic because some of these patients have no or very little muscle symptoms, but have clear skin symptoms. And how these skin symptoms look, I will show you in a minute. They are not really the same as the ones that you know from the textbooks. But something that is interesting is, and this comes from a patient that has died from anti-MDA5 dermatomyositis, is that in the skin you have these obstructive thrombosis features in the small vessels. This is a lung of a patient with anti-MDA5 dermatomyositis with ILD, interstitial lung disease, which is very, very dramatic with these hyaline membranes here. And this really looks like what we have seen in COVID patients in their lungs. So this is really very comparable. On a morphological level in the muscle, on the other hand, so this is dramatic, but in the muscle, sometimes the alterations are relatively mild. Only some areas show the typical perifascicular atrophy of muscle fibers. Only some areas show an upregulation of MHC class 1 in the vicinity of the fascicles, like here. There is no MHC class 2 positivity on the muscle fibers. Of course, there's positivity on the capillaries and of antigen-presenting cells. There are quite some macrophages, but very little T cells, and there's very little complement deposition on the muscle fibers. So the skin symptoms are really different from what we know from what we call Gottron's papules and heliotrope erythema. Here, patients show ulcerative problems, and this is here ulcers on the hands and also on the feet. Those are photos from my colleague and friend Olivier Benveniste in Paris. And again, just to show you that these molecules here, MDA5, are tightly involved in what I've told you about the interferon signature. So upregulation of the interferon signature downstream can be elicited by different triggers. So for example, viral triggers, HIV, a lot of other types of virus diseases. So virus or host double-stranded or single-stranded DNA can lead to an gain of function mutations or upregulation of MDA5, for example, or RIC1, and this will then cause type 1 upregulation of hundreds of different interferon-related genes. And on the other hand, there's also loss of function mutations, for example, in Aicardi-Gouttière syndrome, one of the interferonopathies, where we have a loss of function mutation. And this also leads to the same upregulation of the interferons. So what does this mean on a translational level? So we have now seen that there's a huge problem in about 30% of patients suffering from very dramatic interstitial lung disease, which can be deadly. And what people have done, knowing that this is a group from China, knowing that there is a strong type 1 interferon signature, they used JAK-STAT inhibitors like tofacitinib, but you can use others, of course. They all have a different type of spectrum addressing the different receptor subunits. And what you can see here is that patients with amyopathic dermatomyositis associated with the MDA5 autoantibody taking tofacitinib, they all survived at 6 months. And in an historical cohort, you see that about 30% of those patients die. This is exactly what colleagues in France have seen in a large cohort of more than 100 patients with MDA5 positive dermatomyositis, seeing that 30% of them have dramatic interstitial lung disease. So what can we conclude here? So there's ethical differences. These patients here are quite frequently encountered in countries or in continents like Africa and Asia. There are some differences between children and adults, which I haven't talked about. There's a severe contrast between the clinical disease, but relatively affecting the lungs, but relatively mild affection of skeletal muscles. And in about 30% of those cases, there's a catastrophic prognosis due to the severe lung affection. So we don't know if there's any link to a viral infection yet. And there are some similarities with genetic interferonopathies, and this has been studied extensively this point here has been addressed only in very single and older studies and not recent studies. So the next type of dermatomyositis is anti-Me2 positive dermatomyositis. And you can see that those patients have the textbook types of skin affections, also the heliotrope erythema on the cheeks and on the eyes, also in the décolleté region and on the shawl sign on the back. So this is typical skin lesions that we all know from dermatomyositis patients. At least that's what's depicted in the textbooks. These patients have severe proximal tetraparesis, a relatively acute, subacute manifestation with high CK levels and relatively little organ involvement, namely not a very prominent lung involvement, and it's also not a catastrophic lung involvement in those cases. And although they look morphologically quite severe, there's relatively good response to treatment in most cases. And this is the classical types of dermatomyositis that you see in the textbooks, also on a morphological level, not only clinically. What you can see here in an overview is that you have areas with normally sized muscle fibers, but you have areas in the vicinity of the fascicles where the fibers are small. And then you have inflammation. The inflammation is in the perimuseum, between the muscle fascicles here. And the perimuseum extending here into the perifascicular, into the perimuseal area, sometimes a little bit entering the perifascicular area. And some areas, this is actually the same biopsy here, look really very severe. There's a lot of fibrosis already early on, and this may happen even after several months already. There's always strong MHC class 1 upregulation in this area here, the area where the pathology is most dramatic. So the MHC class 1 upregulation can be identified here, and it decreases towards the center of the fascicle. So I call this centrofascicular towards perifascicular gradient. There's relatively little MHC class 2. Most dermatomyositis cases don't have MHC class 2. The Me2 cases have some MHC class 2 from time to time, but this is actually also not very prominent in contrast to the MHC class 1. Complement is always detectable on the muscle fibers and not so much on the capillaries. And I told you about the MXA stain. Another stain that tells you about the type 1 interferons is the ISG15. Both are strongly positive. And if you want to see the cells that are close to those fibers here that are depicted here, that are obviously involved in the type of inflammation, you can see that these CD169 positive or Siglec-1 positive, specifically polarized macrophages, are very close here to those cells that show staining of MXA, namely the ones that have the interferon upregulated, also on a genetic level if you test it. And then we have the TIF1 gamma cases. TIF1 gamma is a very important autoantibody, because those patients, if they have dermatomyositis and TIF1 gamma and are TIF1 gamma positive, there is a very high risk of developing cancer. And if they have additional features that are detectable by morphological studies, then this risk of having cancer is even more increased. So in other words, we all know that dermatomyositis can be associated with cancer, and in textbooks you will find it's about 20–25% of dermatomyositis cases overall are associated with cancer. But MI2 cases are rarely associated with cancer, and TIF1 gamma cases are often associated with cancer. So this is really important. And just by having the antibody that is associated with the disease, you can already make up your mind in a way towards prognosis. And this is true for patients above the age of 40, 45. It's not true for children, fortunately. So children with TIF1 gamma positivity don't have cancer. This is not described. So this is a good message, at least. So what do we see under the microscope? This is a glomeruli trichrome stain. This is the H and E of the myopathologist, as my teacher Hans Goebel always says. Here we have fibers that don't look very green. So those here are green bluish, but then there are many of them that look a little bit grayish, violaceous, and those have empty holes, and those are the so-called punched out vacuoles. This is something that is specifically seen in the TIF1 gamma cases. You also have so-called ghost fibers that they don't stain with ATP 9.4 or even above, so they are not really visible in this respect in the alkaline pre-incubation. You also have a COX negativity or COX paleness around the perifascicular area in those cases. Very little inflammation. Those are some CD68 positive macrophages, scarce positivity of CD8 cells. And just from a clinical point of view, I'd like to mention that those cases here sometimes have relatively low or even approaching normal CK values, although they are really dramatically affected. But this probably reflects the fact that there is not a lot of inflammatory infiltrates. On the other hand, MHC1 is always positive, MHC2 is not positive at all, always negative, and MXA is positive, and ISG15 is positive. But, and then this is important, complement is on the capillaries, whereas in Me2 cases, it's on the sarcolemma. So here we find it on the capillaries, and the colleagues from this group here, Hida et al. Have published in 2016 that cancer-associated myositis with positivity of these complement deposits on capillaries, punched out vacuoles, have a close temporal associationship with cancer, and they found associations up to 90%. So this is also morphologically important to identify these features, which also again can then inform you about prognostic, about prognosis of these patients. So as I said, Me2 cases rarely have cancer. TIF1 gamma cases often have cancer, and this is just to show you a little bit of more scientific data that we have been able to generate in the past. Here we wanted to know if we look at more genes. So I showed you that most people look at these 10 interferon signatures. Interferon signature associated genes. We wanted to look at more genes, and this is a relatively easy approach by nanostring. Here you can look at about 500 different genes, oncogenes and immunogenes, they are called, so a very large group of different pre-selected genes. And what came out interestingly is all these blue here, blue cases are Me2 positive, and all the red cases are TIF1 gamma positive. And you can see that they clearly cluster. So they are like, from their expression of the different genes associated with these functions here, they are really different. So we said, okay, this is a great result, and we will now be able to identify some molecules, some upregulated genes that will tell us why TIF1 gamma patients are so frequently associated with cancer. But unfortunately, we didn't find them. We are still searching. So this was unfortunately not possible with this approach. Nevertheless, they clearly differentiate, and you can clearly also in those volcano plots here, you can find a different set of genes that are up or down regulated. And nevertheless, we found something else, which is also interesting, but probably not as interesting as the clear association with cancer, or the explanation why this molecule is so frequently associated with cancer. But we found something that we found also very interesting, namely the vascular problem that we all know is prominent in dermatomyositis. So there is a lot of loss of capillaries, dearth of capillaries. And you can see that in Me2 cases, all these violet or violaceous dots here, those are all capillaries. And they are a little bit reduced. So there are some areas where you have a little bit less than other areas, but the severe reduction, as you can see it here, with barely any capillaries, that is something that you find in TIF1 gamma cases. So here we have a clear prominent vasculopathy, which is again different from what we see in the different subgroups. So I did not talk about NXP and SAE due to time reasons, but also those cases are different in a way. But let me talk about IMNM. So this is a different entity called immune-mediated necrotizing myopathy, or IMNM. And those patients here have proximal paresis, tetraparesis, which is lower leg predominant. They have high CK levels, and I would even say, although I'm not a clinician anymore, that a normal CK excludes this diagnosis. So in the early acute, subacute, but also several months of disease, CK is always very high. We have seen very chronic diseases after decades, where the diagnosis has been made after decades of disease, and then the CK levels drop to normal. But in the acute situation, they are always very upregulated. These two antibodies here are associated with the disease. Both of them have some association with the endoplasmic reticulum, I will show you. And it is important to differentiate IMNM because it's a necrotizing myopathy and it's relatively little inflammatory from certain types of limb-girdle muscular dystrophies, namely those that have an association with inflammation. And the two most important ones are dysferlin and anoctamin, and also FSHD. So this is important, and if there is any doubt, either clinically or morphologically, one should definitely go for a genetic disease just to treat somebody who should not be treated, of course. Here we have an absence of the mentioned type 1 interferon signature. And I would say that in any case, you should definitely perform a muscle biopsy. There are people who say that if you have the antibody and a clear clinical picture, then it's not perhaps necessary. But we have really seen cases where we were so happy to have the biopsy because the definite diagnosis was possible in one or the other direction, meaning in the direction of the myositis or in the direction of that we were able to say that it's not a myositis, it's a limb-girdle muscular dystrophy or FSHD. So how does this look? So here we have necrotic myofibers at different stages of necrosis and distributed all over the muscle biopsy. So they are not specifically clustering anyway. There are some inflammatory infiltrates. There's always some infiltrates. So the first descriptions of this entity said that there's no lymphocytes, but that's not true. You always, and we have looked at more than 150 cases now together with colleagues in France, there's always some lymphocytes, but I admit sometimes they are really scarce. There's an upregulation of MHC class 1, which you can see here, which is strong in this case, maybe much less prominent. And overall, I must say that the HMGCR related cases have a little bit less MHC class 1 in our hands compared to the SRP mediated ones. An important issue is the positivity of complement, which was not paid attention to in the very beginning. So there are always a variable number of muscle fibers where you can find complement deposits, either C5b9 or C1q, on the surface of the muscle fibers. And it's the alternative complement pathways which is upregulated here. This is one thing. And the other thing that we have been able to demonstrate a little bit later is the fact that there are myofibers that have a very specific type of staining pattern when it comes to the stains with the autophagy markers like P62, LC3, and others. And this is really different from what we know from IBM, for example, where we have coarse plaques and relatively large areas. Here we have fine granules of autophagy, of small autophagal lysosomes that are positive. And this is very typical for IMNM. And we have been able to study this with a doctoral student here recently, and well, it's now already 4 years ago. And you can see that these areas with the autophagy upregulated in this fine punctual manner, there's a specific type of autophagy that is related to this, which is called CASA, or chaperone-associated autophagy. And those are all molecules that are part of this CASA type of activation of autophagy. And you can also co-localize these molecules to the p62 positive areas. And when you look at the electron microscopy, you can see that there are small areas that can already be depicted here. There are some vacuoles here, and there are these small autophagosomes that are much smaller than what we know from IBM. So this looks very different from what we know from IBM. And this is informative about the ER stress that those patients have. And we have been able to track this by looking at the 3 main phenotypes, namely the PERK, the IRI, and the ATF6 mediated types of ER stress that can be associated with IM&M. And this is Werner Preuss and Andreas Roos who have done this more recently. So concluding here is that we have 2 mechanisms that are important. One mechanism is obviously that we have a myofiber here that is found by the complement system. The complement system is attaching to the antibodies that have attached to the surface of the myofibers, and this leads to a necrosis of the myofibers. Of course, necrosis is followed by regeneration, and we have young emerging myoblasts and myotubes. And in those cases, the antigen, for example, for HMGCR and also SRP are expressed on the surface. And this can now be recognized by the complement system again. So this may be a vicious circle that can be activated here. Another important issue is that many of those patients have in relatively short time severe atrophy. So this is really an atrophic disease. Another thing that I told you is that we have the coupling of inflammation and autophagy via molecules associated with the CASA type of autophagy, and this is all related and preceded by ER stress. So then we have the antisynthetase syndrome. So the antisynthetase syndrome is a disease that is associated with one of the so-called tRNase synthetase autoantibodies. And in the past we had 8, now we have 10, since recently we have lysine and valine in single cases that have been identified last year. But what is important is that those 3 here are the main ones that you will find in patients. And there are areas in the world, namely in Asia, and where colleagues of mine, Ishizu Nishino, for example, have shown, and Suzuki, they have shown that the OJ antibody is particularly frequent in their population. And then we have looked here in Germany and identified that our line blot is actually not detecting those. So we may have those cases, but our line blot that most people use doesn't detect OJ at all or very well. So this is a disease where we have proximal muscle weakness, myalgia. We also have interstitial lung disease, which is less dramatic in most cases compared to the MDA5 dermatomyositis cases. But interstitial lung disease can be quite a problem, and some of those cases don't have a prominent muscle problem in the beginning and start with interstitial lung disease, and even under therapy may later develop muscle problems. So this may occur together, but it may also occur one after the other or be predominant in only one organ, namely muscle or lung. In addition to that, these people have mechanics hands, as you can see here. Sometimes also, if you look at them, mechanics feet. They don't have those skin symptoms. Don't show heliotrope erythema. This has been a discussion and is an ongoing discussion if this can occur or not, and if it occurs, whether one should classify this among the dermatomyositis cases. So this chapter is not closed, but in most cases, you don't find this typical heliotrope erythema in antisynthetase patients. They frequently have Raynaud syndrome associated, and they relatively frequently have seronegative arthritis of the distal joints that can also be found. So those cases look different from what we've seen in dermatomyositis. Here we also have a perivascular pathology, but the perivascular pathology is composed of necrotic fibers and not of atrophic fibers. As you see here, there are indeed some atrophic fibers, but those are the necrotic fibers or the regenerating fibers. And of note, there are within this perivascular area where we have the very small fibers in dermatomyositis, we have very big fibers as well. So this intermingling of small fibers, big fibers, and necrosis is so typical for antisynthetase syndrome. So we like to call this pattern of perivascular pathology the necrotizing pattern of perivascular pathology, whereas in dermatomyositis, we have an atrophic pattern of perivascular pathology. And this is also accompanied by certain further immunohistochemical and also electron microscopic features. First of all, there's always an MHC class 1 upregulation, as in any type of myositis. So if we don't have MHC class 1, it's not myositis. This is something that is a simple truth. So MHC class 1 is positive in the perivascular area. We have MHC class 2, which is very frequently even more strong than MHC class 1. And this pattern of both being positive and both being detectable is so typical for the antisynthetase syndrome, again with this pattern that is most pronounced in the perivascular area. We have also seen that there is alkaline phosphatase positivity here in the perimusial area, which is something that is important. We have activated fibroblasts in the perimusial area, and we have identified something that is really useful, but of course laborsome to detect, are the actin aggregates within myonuclei. So here the myonuclei are important and can help us to identify antisynthetase cases. So what we have seen is that there are a lot of plasma cells here, and you can nicely identify them here on the electron microscope, but of course you can also stain them. And we have been able to identify a number of molecules that are associated with attracting plasma cells and activated B cells towards the area, this perivascular area where these plasma cells reside. And we all know that certain activation types of B cells and plasma cells drive the antibody presentation. So what we think is that, and this has also been shown by activation of certain chemokines as well. So what we think here is that in antisynthetase syndrome, these cells have a particular role. They reside in the skeletal muscles, and the muscle forms an immunological niche, so meaning that these plasma cells can survive there for a longer time, so they are long-lived. And this is a term that Professor Radburg from the DRFZ has invented. Long-lived plasma cells, they have really an important role, obviously, in this type of disease. They are residing in this immunological niche, whereas normally in healthy people, they are, of course, in myeloid tissues. They can be found in myeloid tissues. So we think that the local antibody production is or may be the source of a chronic antibody-mediated inflammation in the muscle. So what do we see in IBM? So this has been really well described over the last couple of years, and I don't want to repeat, but I just like to stress what is important and what should not be missed in IBM. So first of all, IBM is always very, very inflammatory. Just remember what I showed you before. Here you can see that there are a lot of inflammatory cells in between the muscle fibers. So they are in the endomusium, so they are in between the myofibers. There's always MHC class 1 and MHC class 2. If one is missing, then it's not IBM. There's always a lot of T cells, and these T cells, also the character of the T cells, the function of the T cells, the clonality of the T cells, this has been studied by many eminent people in the past, and they have found certain very important characteristics. Still, any type of addressing the IBM by immune modulation has not been successful, or let's say not been very successful. So this is the inflammatory part, and there is also what we call a degenerative part. The degenerative part is actually something that is associated with certain molecules that have been shown to be important in neurodegenerative diseases, like TDP, for example, and also like P62. And I showed you that P62 is important in another disease as well, like, which is IMNM. So here we have so-called rimmed vacuoles. They can occur within the center. They can occur close to the nuclei. They can occur also close to the sarcolemma or subsarcolemally. There's a certain very specific type of P62 positivity. In the past, it was mandatory to do EM and to identify tubulofilaments. As you can see here, this has been abandoned in the latest version of the IBM, defining features by Lloyd and others. Something that is really important and that we are about to study with my younger close colleague Felix Kleefeld is the mitochondrial problem that can occur in IBM. And you can nicely see that there are COX-negative, SDH-positive fibers. They are the bluish ones here. And also under the electron microscope, you can nicely identify so-called paracrystalline inclusions, pathological mitochondria. So a relatively recent finding that Stephen Greenberg, and in parallel, really in the same month, we were able to publish with Samuel Knaus, who found that KLRG1 is actually strongly upregulated on PCR levels or on the RNA level in IBM patients. And if you stain these KLRG1 positive T cells, you can identify them within the muscle of IBM patients. And those patients are, those cells are the same as the so-called TEMRA cells. They are exhausted and they cannot be obviously tackled by immune mechanisms. So what Stephen Greenberg did is to patent this so that people do this and identify and think. And he thinks about, or he has developed, together with pharma company, of course, an antibody against this KLRG1. And this is now starting in trials. Let's see how this evolves. So this is something that is relatively recent and has been used as a possible intervention towards tackling these specific T cells. I think I will jump over this because I have so many other things to tell you. This is, and we don't have a lot of time anymore. So this is something that I would like to stress, and this is really important. This is PM-METO. PM-METO is a so-called early stage of IBM. And in the past, it has been called PM-METO. The term has been coined by Alan Pestronk. And this is just to tell you that those cases which have an MHC class 1 and MHC class 2 positivity, which have a lot of mitochondrial abnormalities, but do not have any vacuoles yet, they develop into IBM. And we have shown this together with Felix Kleefeld in a recent paper that we were able to publish last year, that the signature, when it comes to certain molecules involved into this pathway here, the senescence pathway, and also in type 1 interferon mediated, type 2 interferon mediated, sorry, interferon gamma mediated pathway is very much similar in PM-METO and in IBM. It's really the same. It's only quantitatively a little bit below what we see in IBM. I will also skip this. Just to come to the overlap types of myositis. So this has been studied by many people in the past. The overlap myositis have been studied clinically mostly by rheumatologists and very little on a morphological level. So many people call them overlap myositis clinically because there are two diseases overlapping at least. And on the morphological level, many people call them non-specified myositis to say or to state that they are not falling into the IIMs that I have described before. So here we have a clinical overlap of different types of diseases, which is interesting because this tells us something about diseases in which context myositis can develop. There's often presence of one or more of the myositis-associated antibodies, like Rho52, like PMSCL, like KU, like U1-RNP, etc. So they have been seldom studied in larger series, and pathophysiology is largely unknown. Something unifying for many of them, this is a case of a KU patient, is that they always have MHC class 1 and MHC class 2. The pattern of complement is always varying a little bit, and there's MXA only on some of the capillaries and not on the myofibers like in dermatomyositis. In PMSCL cases can look very mild like here, and this is another one where we have a relatively dramatic infiltration which is really focal. Again, MHC class 1 and MHC class 2 complement is nearly absent. And then in the U1-RNP cases, those are the ones that sometimes develop in the context of scleroderma. Again, MHC class 1 and MHC class 2, no major complement, sometimes relatively little inflammation, like in this case, and also no autophagy-related problems. So this was relatively quick. These cases are now, at the moment, as we talk, studied by different groups, and all the morphological and clinical features are now more well delineated in the future, and this will be done soon. Something I'd like to share with you is the type of myositis that can occur in scleroderma. And we have looked at patients, nearly 20 patients with scleroderma and a defined type of myositis. And what we found, to make it a little bit more brief, is a very prominent capillary pathology. And you can see the different types of capillary pathologies that my colleague Carsten here has found under the electron microscope. There's relatively mild myositis. So there's upregulation of MHC class 1. We have the large capillaries. They are characterized by a proliferation of pericytes that can also be seen under the electron microscope. And there's some complement as well. And this is a cartoon, or this is a 2D EM, where you can see that these capillaries are really strongly affected, and some of them are even necrotic, as you can see here. So there's a healthy one here, and there's a necrotic one just next to it. So those are called string vessels. And again, this is another string vessel. So this is a necrotic capillary. Those string vessels have also been described in COVID, actually, in lungs of COVID patients. So finally, we come to the IR myositis. So this is the type of myositis which is very frequent nowadays, because many patients are treated with PD-1 and PD-L1 inhibitors for their cancer. So this is the immune-related, unwanted, of course, type of myositis that can occur during treatment with PD-1, PD-L1 inhibitors. Of course, you upregulate your T-cell response in these patients directly, which is beneficial in terms of tumor defense. But in these patients, myositis and many other types of immune phenomena can occur. And if it's myositis, the type of myositis is different from every other type of myositis that we have seen, in a way that also the trunk muscles are involved, the eye muscles may be involved, and the neck muscles may be involved. So those are the first patients that we had described in the past. Inflammation is often very severe, and I think I keep it to this. The important message is, if the myositis is associated with myocarditis, then the prognosis is really poor, and these patients have to be treated highly specifically. And it has been detected that targeting the CD28, for example, with abatacept, may be beneficial. And very recently, my colleague and friend Yves Allenbach from Paris has shown that combining abatacept with a JAK-STAT inhibitor is even more beneficial. And finally, to conclude, eosinophilic fasciitis is another rheumatological disease where patients gain weight, have a mild muscle weakness, and they have this so-called growth sign, so the veins are collapsing, and you can find eosinophils in the fascia just adjacent to the muscle, and there's a strong upregulation again in the perivascular area of MHC class 1 and MHC class 2, and of course, these eosinophils, which may be variable. Sometimes they are difficult to find. So those are the take-home messages before I conclude. Dermatomyositis is clearly an acquired interferonopathy. You can use this MXA stain, which is widely available. IMNM features complement-mediated necrosis, and we have a specific type of autophagy called CASA. In antisynthetase syndrome, we have plasma cells and B cells detectable within the muscle. In IBM, there are dysfunctional T cells. We know this, and now we have identified several different molecules which are interesting, and some of them are now addressed in therapeutic trials. In overlap myositis, the features are not so well defined nowadays. In IR myositis, it's important to know that if this is related to myocarditis, the prognosis is very, very poor, and people have to be, or patients have to be treated very, very stringently. There are a lot of types of myositis in addition to those that we have discussed a bit more intensely, where no autoantibodies are found, but they have a specific morphology. And I'd like to conclude with saying that it's really important still to perform muscle biopsy in these patients to have a clear idea of what they really have. So with this, I'd like to thank a lot of people with whom I cooperate. I don't mention them here by name, but they are all written down here, nationally and internationally, and specifically my mentor Hans-Hilmar Göbel and Corinna Preusse, who is my postdoc, with whom I work a lot, and those are funding and associated agencies. And I'm happy to take any questions, of course.
Thank you very much, Werner. I think you gave us the illusion of this being simple, which is always a good sign, but it's rather complex. And we have some questions as you asked. So Dipti Vaska would like you to explain a bit deeper the difference between overlap syndrome and antisynthetase myositis.
Yeah, very good question, very important, I think. So first of all, I must say this is my opinion. There are a lot of other opinions around on this specific topic, and I think there is no right or wrong. Overlap myositis, as you clinicians, or many of you are mostly, I think, clinicians, know much better than me, is defined as two different diseases, one of which is myositis, the other is another disease that can stand alone without myositis, but of course can occur with myositis. And then you have a specific type, often specific type of myositis, which is not so well defined. In antisynthetase syndrome, it's in a way different, because in antisynthetase syndrome, you have a myositis-specific antibody, one of those 10 that I mentioned, A. B, the morphology is always the same. So irrespective of the antibody you have, the morphology is always the same. So they all look very similar. There are mild variances, but overall they look very similar. And of course, clinically, you have an overlap because you have interstitial lung disease and you have myositis. And sometimes, as I explained, they can occur completely separately, or one without the other, and sometimes they overlap, sometimes they follow each other. So of course, from a clinical point of view, it's an overlap type of myositis, but I would say that immunologically and also from the autoantibody phenotype, I would say that it's an entity on its own, which I'd like to take out a little bit of this large basket of overlap myositis types, which are much less well defined. But as I said, this is a view from a morphologist.
So Carl Josef Separa would like you to see, to explain that if in cases of seronegative dermatomyositis, does identification of the interferon signature increase the diagnostic certainty? And would you recommend it in cases of seronegative dermatomyositis?
Yeah. Well, of course, you know, my rheumatology colleagues always tell me that it's not necessary to do a muscle biopsy in all dermatomyositis patients, and then we discuss, of course. And I think they are right. But on the other hand, when it comes to seronegative patients, we have seen surprises. And then the biopsy is, of course, important, but that was not the question. The question was whether we can identify the interferon signature. The answer is yes. It's important to identify the interferon signature. And nowadays, this has been done by my friends and colleagues in Tokyo, Akinori, Rua, and Ishizo Nishino. They have looked at the MXA in a large number of dermatomyositis patients and also in the seronegative patients, and identified this MXA positivity in the perifascicular area as being a very important element for diagnosis. So this is important to do. Yes.
Thank you. So Joanna Dionisio asks if you think that functional MRI could substitute muscle biopsy in the near future. I know you're going.
If you ask me, I say no. No. I am very good friends with a lot of people who do MRI, and I think that those two techniques are really complementary. And I'd like to argue from a non-morphological point of view as well. Of course, you know, by MRI, the advantage that you all know is that you can look at the whole muscle. If you do a whole body MRI, you can look at more or less 40 kilos of muscle, whereas the muscle biopsy are several grams and a certain piece. And of course, also in certain subforms of myositis, if we do a lot of MRI, we realize that there are some patterns that come out. For example, in IBM and also in IMNM, there are certain patterns. I don't know if they are highly specific, like, for example, like the ryanodine-1 receptor or the collagen-6 associated patterns on MRI. But there are some patterns coming out, and this is really helpful. Whereas on biopsy, you can look at the different cells. We will not be able to look at a cellular level by MRI, and you can even look at a subcellular level, at the mitochondria, etc., etc. So from a diagnostic point of view, I would really say that they are complementary. And sometimes I would even say that if you have clearly defined, and those have to be defined, these features. There has been a nice workshop recently about this by Pierre Callier and Marianne de Visser and others who have addressed this issue. So the issue is what do we define as signs of myositis by MRI is very important. And if you have this, of course, sometimes in cases where you have an antibody, a clear sign of clearly clinical signs of dermatomyositis, high CK levels, etc., then an MRI may be sufficient as well, of course. Of course, as always, you cannot answer those types of questions in a general way, but I would not say that it's useful to substitute one technique with another technique.
Well, we have lots of questions. So Jonathan de Winter asks if you think the presence of anti-CN1A in sporadic IBM makes it an inflammatory condition.
Well, IBM is without any doubt inflammatory. Whether the inflammation is secondary or not, there are different opinions on that. But of course, when you look at the biopsies, it's clearly an inflammatory disease. I think the question goes more in the direction whether this is really similar to the immune mechanisms, that it's really an antibody that has the same value, let's say, as the TIF1 gamma or the ME2 cases? And I would say no. And it has been proven by others, not by me, that the CON1A antibody or MUP antibody can be identified in some other diseases as well. In dermatomyositis, it has been shown. It has also been shown in lupus. It has also been shown in normal muscle from time to time. So the value of the antibody is clearly different from the so-called myositis-specific antibodies. I know that it's always grouped among the myositis-specific antibodies, but I would really take it out there and put it separately, because it's not so specific. The usefulness is, I'm not a clinician, but I can say that many clinicians tell me that they use it quite, and they like using it. I think it's quite supportive of the diagnosis, and some say that presence of the antibody allows them to make a prognosis of a more severe phenotype, which has been discussed by others, and they don't think so. So that's all I have to say to this.
Well, the questions continue, but I'm afraid we've exceeded our time. And
send me emails if you want to.
So you have that nice suggestion from Werner. Send him the emails with your questions. And I would like to finish by thank you very much for this very nice talk. And as you know, this is going to be edited and put out in our website for on-demand viewing. And thank you very much. And I hope to have you back in another webinar very soon. Thank you.
Thank you. Nice,
Bye.
nice Easter holidays.
You too. Bye.